Welcome to the Retain It webinar series on solutions for achieving surgical and restorative success in the edentulous mandible. It's being presented by Dr. Matthew Hallis. He's the founder, owner at Bay Lake Center for Complex Dentistry. And with that, it is my pleasure to introduce Jean Patterson, Director of Technical Development and Learning for Stern Gold. Take it away, Jean.
Thank you, Jessica. It's great to be with everybody. You're in good hands. This is a great series that you're taking part in, the Retain It series with Dr. Hallis. So there's going to be a lot to learn. It's going to be a great experience. On behalf of Stern Gold, we're proud to present this. On behalf of Patrick Hayden, our sales director, he's going to be with us tonight as well. We welcome you tonight, and I'm going to turn it over to my friend Dennis Urban from DSG.
Thank you, Jean. Thank you, Jessica. This is probably one of the hottest topics in dentistry, implant dentures and restoring a fully edentulous ridge patients. And I don't think there's a day that goes by that I'm not on the phone speaking to a doctor or a colleague about implant overdentures and protocol and what to do. What Dr. Hallis is going to talk about tonight is some great solutions. Part one in a 5-part series. So we're really happy to have him here tonight and just to get his knowledge base and get his message across to everybody. So, and Dr. Hallis is going to give you a little background on his bio, what he's achieved. So I'm going to turn it over to Dr. Hallis. Thank you so much, Dr. Hallis, for being with us, and take it away. Appreciate it.
Perfect. Thanks for the introduction. And also thanks for hosting and sponsoring both the Stern Gold and DSG for hosting Retain It, as we talked about. So who am I? Where am I from? Where am I? What are we going to talk about tonight? So I grew up on the East Coast. I went to Tufts Dental School. From Tufts, I chose to go to UIC for advanced pros. Unique program there where we were trained both in the surgery and the restoration. So I have a unique perspective in how we do these cases, how we work in collaboration with our oral surgeon, how we treat and plan in-house. So we're going to kind of go through some of those insights. From there, I somehow ended up in Green Bay. I'm a co-owner of Bay Lake Center for Complex Dentistry. We are very fortunate to be up here. We have great fishing, hunting. My main passion is fishing and hunting, and that's truly what brought us up here. When I wasn't doing dentistry, I was fishing with my wife. And ironically, how I ended up in Green Bay and then satellites in the Upper Peninsula of Michigan is because of fishing, and there's not many prosthodontists that fly fish with their wives. And we became friends and then colleagues and then ultimately business partners. So I'm very fortunate. I have a good friend. We have a true pros practice where we have a referral-based practice. We do a lot of marketing. And I focus solely on doing implants, restorative dentistry, and advanced cases. Through our 3 satellites that we have a lot of windshield time. Our day-to-day practice, there's not a day that goes by that we're not working with some type of implant and doing some kind of full mouth transformation, single tooth implants, smile transformations. But I really believe that if you're not providing implant treatment, you're not providing the standard of care. Kind of what Dennis said, there's really not a day that doesn't go by that we're not figuring out a way to utilize implants. And today what we're going to focus on is overdentures. And in my opinion, mandibular overdenture is standard of care and truly a game changer when they're done well and done correctly for a patient. What's important? I am paid to speak by several companies. Today I'm paid to speak by Stern Gold. I am not paid to use any products. The products that I use in my office, I pay for it just like you guys. I don't have any special contracts with any companies. I do that because at the end of the day, I am a clinician and my sole responsibility is to treat patients. So if there's a better product, I assure you I would use it and I would end up talking about it. So that is something that's quite important is I'm not paid to use the products. I'm paid to speak to you guys tonight. So any questions on stuff we use, this is what we do use in our office, what we show, all the pictures and cases are mine. So as we go through, if anybody has questions, feel free. Prior to COVID, I did force everybody to see my family vacation photos. But you know, with COVID now, I sit home, do a lot more dentistry. I'm very fortunate. I work with my wife. She's our office manager and kind of oversees the ship, keeps my partner and I in line. I have 2 healthy kids. I have a 5-year-old and a 15-month-old. She is a handful. It's fun now that Hunter's really starting to come into his own, and we're starting to take him hunting and fishing. So with that said, let's talk about what we are going to be talking about tonight. We're going to have a 5-part instructional course that's going to combine multiple surgical and prosthodontic procedures to enhance the participants' knowledge in both the surgical and restorative aspects of the implant overdenture therapy. Okay, it's going to be once a week for the next 5 weeks on Thursdays. What we are going to talk about tonight, okay, this is one of the most important steps, and I can't stress this enough, is diagnosis and treatment planning. If you start with a poor plan, you're behind the 8 ball. It does not turn out well. There is no way to basically circumvent backwards and try to replan. Okay, so the first thing we're going to talk about is truly diagnosis, treatment planning, and a complete denture exam. We're going to review the medical history. We're going to talk about treatment options for the edentulous patient. We're going to talk about pre-treatment intraoral examination, review the anatomy for mandibular overdentures, and then we're going to talk about restoration by the numbers. This is one of the biggest mistakes and errors that I typically see, is not understanding the amount of restorative space we need for a mandibular overdenture. There's fixed numbers that are really not negotiable. You need space. We need space for acrylic. We need space for attachments. We need space for teeth. At the end of the day, an implant system is a large erector set that we have to figure out how to utilize these pieces in a fixed, confined space that's going to function and look aesthetic. Going forward, we're going to talk about a handful of different topics. The next lecture is going to focus on implant placement for mandibular overdentures, identifying cases for implant overdenture therapy. We'll talk about surgical protocol. We're going to review post-op complications because that is important. If you're not having a complication, it means one of two things. Either you're not doing the procedure or you're lying. Okay. At the end of the day, there's few complications that do occur, and we got to talk about how we handle them. The following lecture, okay, this is something that we use in our office, depending on what the case is presenting. And we use mini dental implants to enhance the healing phase. And what we're going to talk about is case selection and utilization of the mini dental implant for provisionalization. That stage where we take the teeth out, we have a sloppy temporary denture with healing implants that we're going to put a stern snap or a locator on of some sort, but we have that 4 to 7 months where the patient is not happy, and we need to kind of carry them through that procedure. We're going to talk about the modified surgical protocol. We're going to talk about restorative options and protocols, and then the post-op. After that, we have the implants in place. We have our treatment plan that we're executing. Now we need to restore it. So we're going to talk about the restorative options for mandibular overdentures. We're going to focus on the attachment design, selection, and what options are available. And then we're going to focus, which is a very important step, is the clinical application of these attachments, how we choose, what we're going to use, why I chose that one, and then how do I attach them. Then we're going to talk about the maintenance, because once we restore it, we do have to follow up with these patients. And then what kind of restorative complications are we going to see, and how do we manage those? And then the final part is basically integrating this into your practice. And I'm going to give some perspective on how we market, choose different education paths. Not everybody has the background that I may have, where I was trained both on surgery and restoration, but everybody has to continue to learn. I mean, I take courses every quarter. We're all required to do CE. So you have to choose and select what course is going to be effective to achieve what you want in your practice. We're going to talk about some different marketing options. If patients don't know you do it, you're not going to have that patient in your door. And then ultimately, we're going to talk about what's a key to success is patient selection and presentation, identifying those cases to start with, which cases to refer. During the lecture, I'm happy to answer questions. I would like to keep the lecture to about an hour tonight, so I would prefer to answer questions at the end of the lecture. Dennis is monitoring them, so if there's something pressing, please feel free to enter in the question section, but I will spend a bunch of time tonight. If we have 10 minutes, 15 minutes, it doesn't really matter. I'm happy to answer anybody's questions. All right, so let's get into the main part of the lecture and really talk about this. The market potential. It is a very common handicap, edentulism. It's present, okay, worldwide. It's increasing, okay. By 2020, they expect the edentulous patients, okay, truly edentulous in one or both arches to be about 37 million patients. Conventional dentistry, okay, hasn't really changed much. At the end of the day, we have fancier acrylics, better teeth design, the new composite teeth. But in reality, when we look at it, 200 million per year is spent on Fixodent alone in the US. So that tells me one of two things. One, either patients really like the taste of Fixodent, or we have dentures that are not achieving the results patients want. However, where I use a lot of implants in my office, okay, is the changing face of edentulism. The soon-to-be edentulous patient, a patient that has avoided the dentist for 10, 15, 20 years, afraid of the dentist, embarrassed of their smile, and now they have a failing tooth or multiple teeth. They might have pain, and now we need to transition them from a terminal dentition that is working in some manner to a denture system in some manner. And this is where I utilize implants in our practice, and I utilize the mini implants, and I utilize conventional implants. So that is what we're going to focus parts of the lecture on today as we go through it, and then in the next coming
Put
series.
$100 at the entertainment center. Let's go to work. We're supposed to go out to eat on our anniversary. When I came home, the $100 was gone. He was gone for 2 days after that. And when he came home, I asked him what happened to the money because he didn't know what happened to it.
You can see here the teeth.
So as funny as that is, it has to bring you to a conclusion or a point and something to really think about. Today, I just met a patient, hasn't been to the dentist in 20 plus years, severe periodontal disease, mobile teeth. I think honestly, half her teeth are being held in by calculus, but it's an important point. Patients are afraid to come to the dentist. A majority of the patients don't like coming in. They don't like their image. They're afraid that they're going to be without teeth. They're embarrassed that they got to this point. They alter their social behavior. This is crucial in these cases when we're talking and relating to these patients, that we truly understand why they haven't come into the office and reassure them that we can fix this. These are teeth. This isn't a heart problem. I can fix this. We just have to figure out how to make them comfortable and choose a restoration that is going to serve them well. Evidence from the New England Elder Dental Survey entitled Oral Health in America strongly suggests that many edentulous patients wear removable prostheses that are totally inadequate to meet the basic needs of function, phonetics, and aesthetics. 2004, the completely edentulous patient meets the World Health Organization's definition for being handicapped since patients avoid eating in the company of others due to difficulties chewing. McGill consensus stated that the first choice standard of care for treatment of the edentulous mandible is the use of an overdenture prosthesis retained by 2 dental implants. This is something I strongly believe in, and this is something we focus on in our practice. Okay? When we look at this and we have to think about what are the challenges presenting these patients? Why are they embarrassed? What is occurring? We have to think as they lose teeth, we have facial collapse, we lose vertical dimension, we get collapse of the bone and resorption. This all in turn affects their ability to chew and eat and avoid certain foods. And this is a slide that really take a picture and commit to memory. This is something that I truly explain to patients in depth. And if you think about it, you wouldn't go to a car dealership and buy a car without looking at it, test driving it, sitting in it. The challenge as dentists is we can't give that patient an overdenture versus a denture and let them try it out. We have to communicate what we can achieve in a realistic manner. So when you think about this and they have all of their teeth, they're at 100% capacity. When they don't have a tooth or teeth, and they don't have a denture, 0. A lower denture is 10% functioning capacity. And that's something I do believe, okay? Game changer for a patient. 2 implant overdenture retained in the mandible, 60% functional capacity. So we have to realize and explain to them what are going to be the limitations. Fishtail motion. It is a denture. It's going to have flanges that extend to the vestibule. It is going to be bulky. It is a fancy plastic at the end of the day. So they have to understand what we can have. But now we don't have the tongue kicking it around. Okay, they have increased biting force, security of their denture. And another big point that I always explain to patients is I do a lot of fixed implant reconstruction on 4, 6, and 8 implants. And even though I'm restoring their teeth to the best of my abilities and as close to their natural teeth as possible, it is not their natural teeth. And there's compromises. They don't have proprioception or periodontal ligaments. The restorations do have contours that are not the same as natural teeth. So we have to really explain this slide to them through demonstration models, review of the x-rays, of truly what we can achieve as dentists. So where do I use dental implants? Okay, any edentulous patient or soon to be edentulous patient that wants to increase the retention of a removable prosthesis in either arch. Okay, but the big one, when they come in and they tell me they wish to improve their ability to masticate food, if they want to increase their biting force, that is where we are placing implants. Okay? And this is an important testimonial. And I talk to a lot of patients. If you look at our website, you'll end up seeing a lot of different testimonials on what patients say. And this kind of drives home points as I'm presenting cases to a patient. So going for a removable prosthesis on implants was the best decision. We were both a bit worried about the surgery at our age, but the benefits of going through this process are more than rewarding. Remember this, the wife's not happy, the husband's not going to be happy, or vice versa. And I like how they say we were both a bit worried when only one of them is going through it. I can eat everything I want. I feel totally secure when talking to other people, and my husband's and my quality of life has increased tremendously. Life's fun again. I do not mind removing my denture for cleaning, as it allows me to feel very clean and easily give me that fresh feeling. That's an important statement as we start talking about this is, does the patient mind removing their teeth, or do they want them fixed like their teeth? Okay. And when I start presenting options to patients, I have to present in a simplified approach at first. Okay. And two of the options that I talk to patients are an overdenture on 2 or 3 implants. We'll talk about that, how I use 2, how I use 3. Okay. Versus a complete denture, and then fixed on 4. Do I use more implants? 100%. Okay. Will I sometimes put 5 in, 6 in, 7, 8 implants? Yes. Just depends on the restoration we're trying to achieve. But I have to initially start at a baseline and simplify the approach and not overwhelm that patient. On here are my 3 options. We have a complete removable option, we have an implant retained option, and I have a fixed option. Where do we want to be in terms of timeline, budget, amount of procedures that we're going to need? And then we start honing in and finalizing that restoration. Contraindications for implants. This is an important one, right? Manual dexterity such that they cannot remove the appliance. We have a lot of elderly patients in our population of our office. And when we think about this, they have to be able to remove this. They have to be able to clean it. If they can't, can the nursing home aide do it? Can their child or children that are helping them or living with them help them? We have to think about this because they do need to maintain it. You can't snap it in and then say, see you in 6 months and we'll clean it again. That does not work. Okay. Medical history, I don't usually worry too much about. Do we have to manage the medical history? Yes. Are there clear contraindications? Uncontrolled diabetes? Yes. History of bisphosphonates that are a high risk? Yes. But in reality, most of them can be managed. Hey, I'm not talking about this in our lecture today or this series, but one of the big contraindications awarenesses for me in my office is a maxillary palataless overdenture with 4 locators that are unsplinted. That is a problem long-term where the implants are at significant risk. So that is something that I do watch. In the mandible, smoking doesn't seem to affect the implants as much. Is it a risk and is it a risk and an awareness? Yes. Is it a contraindication? Absolutely not.
Hello, I'm your dental hygienist today.
I hate going to the dentist, and I already know that I hate you.
Oh God, here we go. How long has it been since you have been to a dentist or have had a dental cleaning?
I only come to a dentist when I have a severe toothache. It has been 5 years since my last cleaning.
Do you have any pain in your teeth? Are you healthy? Are you on any medications?
My teeth spontaneously explode. I am on 50 medications, and I do not know what any of.
Depending on where I am in the country, it starts swearing, and that's not really good. I just got back from a tour in Salt Lake City, Boise, Idaho, and that wouldn't be good for the lecture. So we cut that off there. But now we moved from talking to the patient, assessing function, capacity, what we can achieve. Now we have to sit in the operatory and look at pre-prosthetic and surgical evaluation for this patient. Okay, this is an important statement. The stable process and successful long-term results for 2 implant overdentures in the mandible cannot be transferred to the maxilla. A maxillary implant overdenture needs more support, preferably 4 to 6 implants splinted with a bar, to reach similar results as a 2 implant option in the mandible. So every patient that comes into my office starts the same. It's patient interview, medical dental history, clinical examination, diagnosis, treatment planning options, and then sequencing. They got to understand what timeline it's going to take. What are the procedures we're going to do? If we have a complication, how is that going to affect their treatment? Where is their temporary phases? What adjustments are we going to need? Okay. So every patient that comes in, they meet our dental assistant, they take a blood pressure right off the bat. Okay. We have a lot of patients. Even if I'm not doing surgery on these patients, I have a lot of elderly patients that I may be doing multiple crowns on, 6, 8, 10 crowns, using a handful of anesthetics. I want to make sure I don't have a complication in my office. So do we take blood pressures on every patient? Yes. Do I update it regularly? Typically, the girls update it every 2 to 3 months when they're doing the paperwork updates. We don't update it every appointment. That's up to you to do. Okay. The next thing that we use, and I highly suggest using if you don't use it in your practice, is the Lexicon. Okay. What this is a online review of the medications, and it gives you key information of what those medications affect in terms of local anesthetic, vasoconstrictors, effects on dental treatment, and effects on bleeding. It is a summary of findings. I don't do this. My assistants plug it in, or my front desk patient comes in, gives all the paperwork, they plug it in, they put it in the chart for my review. I think this is something that is a key to not missing something. I'm very up on most of the bisphosphonates, a lot of the drugs that affect bleeding, but there is constantly new medications out, and I'm not a medical pharmacist at the end of the day, so I want to double check. And this is a quick, easy, efficient way to avoid complications and headaches throughout your day. Next, we're going to be talking about surgery in the next 2 lectures. So we got to think about what can cause problems. Blood thinners, okay? The Xarelto, the Predaxa, the Eliquis, okay? The problem is there's no predictable reversal agent, and it's a 12-hour med, so they're going to bleed for 24 hours. Okay? You have to look at your protocols, decide on how much surgery you're going to be doing on this. What is the risk of bleeding? Are they on other blood thinners? Are they a diabetic? Okay? As dentists, we do not alter or stop any medications. I talk to their physician, I tell them my plan, and I see what we can alter. If I have any worries, I work with my colleague, an oral surgeon in town, and I let him deal with this, okay? From there, bisphosphonates. Problem we all know is it irreversibly alters the osteoclast, leading to the possibility of osteonecrosis. When these go bad, like the Fosamaxes, the Bonivas, we have problems. Luckily, the problems are isolated, okay? But we need to manage our problems. We need to assess the complication risk, okay? This is a great paper to read. It's a 2014 update, special committee position paper by Amos in regards to the medication-related osteonecrosis of the jaw. I highly recommend reading it. It ends up giving a handful of key information on what's really up to date. Okay? Couple things to think about for clinical implications are 33 million prescriptions are written worldwide for oral bisphosphonates. However, 30,000 cancer patients are receiving high-dose IV bisphosphonates for bone involvement by cancer. But the challenge is, as people are living longer lives, we're exposed to more carcinogens to our lives. There's an increasing number of cancer patients on these anti-angiogenic agents. In reality, these agents are starting to cause more problems than the bisphosphonates, and we really should change the bisphosphonate-related osteonecrosis of the jaw to medication-related osteonecrosis of the jaw because of the growing number of cases that we are starting to see. So you really have to review the patient's history. Have you had a history of cancer? What medications were you treated on? If you don't know and you're doing a complex surgery case, this is one where to request the medical record from their doctor. Okay, the risk of ONJ among cancer patients not given bisphosphonates is low, under 1%. Now, the risk increases when the patient's exposed to Zometa by 50 to 100. Increases again if they were on the cancer drug Densub, and the risk is additive when they're on combinations of anti-angiogenic drugs and bisphosphonates. So we have to kind of look, is this a diabetic patient with a history of bisphosphonates, maybe a cancer treatment? And then we have uncontrolled periodontal disease with bone infections going on. So that is a risk that you have to be aware of. Some of the drugs to really be aware of, the Densub, the Prolia, the Avastatin, the Zometa, big names, problems. These are the ones that have the high risk. And it should be stressed that 92% of the reported cases of MRONJ occurred in cancer patients who received high-dose IV bisphosphonates. The other 8% of the reported cases received oral or low-dose IV bisphosphonates for treatment of osteoporosis. Okay. Now, this is something that we're seeing in our practice. Okay. So I have a implant-focused, heavy restorative implant practice. We have a full-time hygienist. I typically send patients back to their general dentist to be maintained, but sometimes I see patients once a year. Their general dentist sees them once a year. Sometimes we take over the care just based on the complexity of the implant reconstructions. Problem I'm noticing is reclassed on integrated long-term restored patients is I am seeing inflammation at the gum line, almost like a peri-implantitis. This is one that's really brought to my attention because I've seen it on multiple patients across the board. So this is something that I do change their recares to if they are on this medication. I will typically move them up from 6 months to 4 or every 3 months. I will call their doctor and find out, is there another medication that we can get them on? And we put them on a strict oral hygiene protocol with electric toothbrush, super floss, water pick, because I do not want to have problems down the line. So I haven't seen bone loss, but I started seeing inflammation with these bisphosphonate class. So it's just an awareness. Next, diabetes. I get a lot of questions with this. Okay, slows our healing process due to being prone to infections. Okay, there is a high success rate of implants placed in diabetic patients when it is controlled. When you see 3 or more diabetic medications, they are not well controlled. The first thing I ask that patient when I notice that they are a diabetic, or if they check that box or I see the diabetic medication, is what is your HbA1c? If a patient knows it and rattles it off like that, if they say they're 6.1, I believe them. If they go, well, doc, it hasn't been great, it's probably a 9, maybe a little higher, that means it's probably 13. I ask if I can call and contact their doctor and get their latest HbA1c. They say yes, and I verify that. Okay. I do not take the patient's word that they are controlled. Okay. Normal control, okay, is probably about 6.5. I have my cutoff range. Oral surgeon has his cutoff range where he will work. The higher the number, the higher the complication rate. The patient needs to be aware of this. Smoking, as I said, I have a separate consent form. I do inform that patient that smoking is essentially like buying a new car and parking it at the beach outside. Okay. We know there's going to be problems. There is risks. Okay. There is a higher incidence of bone loss. Luckily in the mandible, we're in better bone, denser bone. I typically do not see the complications that I see as with the maxillary overdenture. So I do make them aware that they are at risk of peri-implantitis, peri-implant bone loss, potential loss of an implant, problems during healing, during extractions and bone grafting procedures, and we make them aware of that through a separate consent form. Okay. Any questions, doubts in the case on their medical history that I have, I send their medical physician or whoever their treating physician is a consult for clearance, and I tell them the planned procedures, the timeline, the medications and the anesthetics I plan to use, pain medications. Okay. From there, it's reviewed by me. I send it off to them, and the physician will either send back notes to modify, adjust, or approve. Okay. If I'm asking for medications to be changed, or if I'm asking to stop their Xarelto or their aspirin, I do not stop it without an approved signed consent form. Okay. I'm not a doctor. I'm a dentist at the end of the day, and I am not managing them medically. After that, we've met them, reviewed their medical history, talked about some risks, reviewed their complaint and their chief complaint, and now we have to start recording stuff and documenting. So chief complaint, critical. You have to identify why are they in our office. After that, we're going to look at denture anatomy. What type of radiographs are we going to take for implant placement? From there, prosthetic space analysis, biomechanics and optimum number of implants, and then we're going to ultimately talk about attachment design, options, and applications. So this is what we kind of need to focus on over the next 4 lectures on how are we going to diagnose, treatment plan, execute the case, sequence the case. So I like this. My dentures don't fit. It's painful to bite, and my dentist will not listen to me. Okay. So it's a typical new patient, referral patient that I see. I see a lot of severely resorbed ridges that people don't want to work on. That is what we focus on. So 30 plus years of wearing complete dentures, new dentures fabricated 6 months ago. Recently, patient has pain on biting with the mandibular denture, not pleased with the aesthetics of the complete dentures. So this is important. Okay, when we are considering between a fixed restoration or a tissue-supported overdenture, are the patient's subjective symptoms more related to looseness or pain? This is an important statement to remember and kind of look back at what this patient said. Recently, the patient has pain upon biting with the mandibular denture. Severe mandibular resorption with the mental foramen in the superior position on the ridge results in impingement and pain. The only way to relieve that pain is a fixed restoration and get it off the ridge. An overdenture is still going to rock and impinge in that area. So we have to decide, is that pain a result of an overextension, a sore spot, a tori, or is the foramen typically located on the superior portion getting pinched and causing pain? So this becomes an important concept when we're listening to their chief complaints and we're doing our diagnosis. Okay. Quick paper of evaluation. Okay. A within subject comparison, patient satisfaction and quality of life between a 2-implant overdenture and a 3-implant supported fixed dental prosthesis in the mandible. Within the subject comparison, they tested the null hypothesis that there is no difference in patient satisfaction and oral health related quality of life when an individual with an edentulous mandible is rehabilitated with a 2-implant overdenture or a 3-implant fixed supported prosthesis. Conclusion: both treatment modalities provided a significant and similar improvement in patient satisfaction, and I see that across the board in our office. Okay? However, a statistically higher score was reported for stability, retention, and ease of chewing with the fixed dental prosthesis, and I fully believe in that statement. The overdenture is great, and it's a game changer for patients, but there are compromises. Okay? It is going to rock. It is going to be extended into the vestibule. It is more bulky. You do have less biting force. Okay? And what we have to do is make patients aware, and we have to figure out this restorative space and identify transition zones. What's important, and I look at every patient this way, is I think about the type of defect I am going to be treating. From there, I think about smile line and prosthesis emergence profile. I have to hide a lot of components and make things look natural. And if I do my job correctly, the only thing the patient is going to see, or somebody looking at that patient, is their smile line, right? There really should not be a big difference from noticing between an all-on-4 to an overdenture to a complete denture. We have to hide the components. And when we think about what kind of defect the patient's going to be presenting with is multiple missing teeth, or fully edentulous ridge, maybe a severe resorbed ridge, high floor of the mouth. And when the image of a complete mandibular denture is superimposed over a panoramic radiograph of 2 implants and ball abutments, the dimensional requirements for a successful denture construction are clearly illustrated. And it kind of starts putting a picture in your head of how much space we're going to need. When there is greater than 10 millimeters between the alveolar crest and the planned occlusal plane, there is often insufficient space to house an implant abutment and attachment housing in sufficient thickness of acrylic to preclude complications. Number one complication I typically see with a mandibular overdenture system is inadequate restorative space with too thin of acrylic that leads to fracture of both the teeth and the acrylic. You have to think about what acrylic is. It's plastic. It's a brittle material. It doesn't have crack propagation properties. So it can crack, and when it cracks, it splits. So when we're looking at it, and as I said previously, we have to simplify the options and explain to a patient, we can do fixed on 4, 5, or 6 implants, okay? It's soft tissue contact, fully implant retained. Now, we do an overdenture, okay? It's going to enhance the retention. It's soft tissue supported, implant retained, preventing vertical displacement, but you're still going to have posterior fishtail motion. And we're going to talk about the factors that are going to affect that. Okay, I like statement. Removable restorations require more maintenance than their fixed counterparts. A patient presenting with a satisfactory complete denture requesting a transition to an implant-supported restoration may be a difficult patient to satisfy. So we have to think about this statement as we start assessing patients. Informed consent must include surgical risks of treatment as well as a realistic assessment of whether the patient's chief complaint can be addressed and their expectations satisfied. Remember at that new patient exam, when you first meet the patient, one of the first questions I ask the patient is, why are you here and what can I do for you? What do you want to achieve? Okay. Clinical studies have shown that ratings general satisfaction were significantly better in patients treated with implant overdentures compared to complete denture users. Fully believe in that statement, as I've said. So first thing we're going to do, patient comes in, I'm going to evaluate their current dentition or their current denture. In this case, we're going to assume they're in a denture, they're unhappy. So what do we have to start looking at? First question I ask them is, why are you unhappy? I don't like the size of the teeth. My midline's off. I think they look like chiclets. There's a difference between 6 and 11. It feels like it's rubbing here. Maybe my upper lip is pushed out too far. So what I'm starting to look for is, where's the extensions? Where are the borders? Is there adequate retention and resistance form? What is overextended? Is there sore spots? Is there an epulous fissuratum? Is there a good occlusal scheme? Did they use lingualized occlusion? Are the teeth worn? Okay, so these are all things that I start looking at and document. From there, I start looking at judgment of facial support. Do they have a denture look? Do they have angular chylitis? When they're speaking, are their teeth banging together? Is there adequate space? I ask them, do you have problems chewing? What foods do you have problems eating? From there, I start looking at lip support, and lip support is derived from the alveolar ridge shape and the cervical crown contours of the anterior teeth. The preference of a removable design will be influenced by the need for lip and cheek support, which can often be predicted by the thickness of the buccal flange of an existing denture. So we have to start looking, is it over-contoured? Is it bulky? I ask the patient, show me where you think it's bulky, so to make sure that I'm not interpreting something different than they are seeing. If the anterior-posterior resorption exceeds 10 millimeters, a removable design is typically indicated for adequate soft tissue support. After that, we got to start assessing their OVD. And there's 5 factors that I use: interocclusal distance, face form and aesthetics, history of wear. How did they get to this point? Why are their teeth worn so much? This patient was a carpenter and puts nails between their teeth. Parafunctional habits, and then closest speaking space. The appropriate interocclusal distance is in about 3 millimeters for a skeletal class 1, but maybe less for a class 3 and more for a class 2. So we have to start putting numbers to paper as we're assessing occlusal vertical dimension. Now, this is something that was stressed to us in our residency. There's no absolute method to determine an acceptable occlusal vertical dimension. It's more like a roadmap, where clinically speech and functional analysis are a key factor in determining acceptable occlusal vertical dimension. They need to be able to function. It has to be aesthetic. They have to be proud of their smile. The S sound is used to measure the closest speaking space, F sound to locate the incisal edge of anterior maxillary teeth, so I use very funny and Mississippi, and then the M sound to locate the mandibular rest position, mama or maximum. When we're using this and we're assessing for vertical dimension of rest, okay, there's no tooth contact. It's a habitual postural position that is neutral and unstrained and is clinically used as a reference position to determine VDO. One of the things that I like to do is for the M sound. So the first thing I do, and looking for the rest position, is I put a dot on their nose and a dot on their lip, and I ask them to bite down unstrained lip position. That marks their VDO. After that, I have them wet their lips and I have them say mama or Emma, okay? And I have them repeat it a few times saying mama, Emma, mama, Emma. When the patient has rehearsed this procedure, I ask them to stop all jaw movements when the lips lightly touch. At this time and point, I measure the space between those dots, and that tells me how much rest position space I have, okay? After using that, I start looking in the mouth. and I'm looking for a fixed landmark that's reproducible. Okay, the incisive papilla is a fairly constant position due to the resorptive pattern of the maxilla in the anterior-posterior direction. The labial surface of the canines and denture should be 8 to 10 millimeters anterior to the middle of the papilla. Tips of the canine should be set on a horizontal line that passes through the posterior border of the incisive papilla. Traditional guidelines tell us that when the patient makes the F sound, the incisal edge should touch the vermilion border of the lower lip. Once the incisal edge position has been established, the length for the central incisors is determined. The proper AP positioning of the incisal tip is largely determined by the opposing dentition. That's a critical statement, which plays a vital role in the amount of overjet and overbite. If a patient comes in complaining about the upper denture, you have to evaluate the lower denture, or the lower dentition. Don't have blinders on and be pigeonholed because we can't have control of both arches. You have to look, you have to assess, and most of the time I have to treat both arches for control of tooth position. The labial dental consonants, F and V. When an F sounds like a V, the maxillary anterior teeth are too long. The thing I do is I ask the patient to say very funny. First thing I do is I'm listening. How do they sound? And the second thing I ask is how do they feel they sound? Do they feel they're lisping? Do they feel they're speaking clearly? Are they enunciating their words correctly? The production of CH, S, and J sounds brings the anterior teeth close together. When correctly placed, the lower incisors should move forward to a position nearly directly under and almost touching the upper incisors. As I speak and I read through our slides and I'm talking to you guys, my teeth are not banging together. Okay, that's important. Our teeth are not touching during function. Our teeth touch when they are functioning on chewing, right? The distance is too large. It means that too small of a vertical dimension of occlusion may have been established. The anterior teeth touch when the sounds are made. The vertical dimension occlusion is probably too great. So what we have to think about is what are the effects that can occur with incorrect vertical dimension? With increase, right? There's clenching of teeth, there's discomfort, there's clicking, loss of freeway space, elongated face appearance. If we've decreased the vertical dimension, we have reduced masticory efficiency, poor aesthetics, you have a denture look. Probably you're going to develop angular cheilitis long-term, prognathism, and pain in the TMJs. So now we have to start thinking about, we looked at verticals, we've started looking at their dentures. Now we got to think about where are these implants going to go? How much space do we need? If we're using a locator type system, how much space does that occupy? How tall is the abutment? How tall is the working space? How tall is the attachment? How much acrylic do I need surrounding this to prevent it? How much space do the teeth take? So anatomically, we have to think back to our dentures. Where's our primary load-bearing areas? Retromolar pad, buccal shelf. What I'm starting to look for is a few key things. Is it a knife edge residual ridge? Is it a broad, wide ridge? Am I going to have pressure spots? Are there undercuts? Tori? Where are they? Do I have to think about removing those tori, or can I work around them? And then the next big thing is, where is their tongue position? Is it enlarged? Is it laying across the ridge? If I ask that patient to lift their tongue up and I have a mirror down in the corner there, does that mirror move 8, 10, 12 millimeters? And what does that affect? That affects your fishtail motion. If I have broad, wide mandibular base ridges there, I have a good stop, good retromolar pad for a reference, okay? Little tongue movement, not enlarged, not laying across. I'm going to have minimal fishtail motion. Now I have soft, compressible tissue, mobile tongue, high floor of the mouth position. That fishtail motion, or that rocking from the front to the back where the implants are retaining it vertically, is going to be far greater. What is the opposing dentition? Okay, and then the type of attachments are going to affect the amount of fishtail motion we have. So, looking in the mouth, okay, height of residual ridges provide lateral stability. Do I have a moderate to severe resorption? Do I have tall ridges? Are those tall ridges limiting my interocclusal space? Where is the tongue in relation to these ridges? Is the tongue up here enlarged? Okay, is that floor of the mouth highly mobile? Where is the buccal shelf, the retromolar pad? Are there undercuts on this case? Okay, are the ridges parallel, or do I need to think about planing them down? From there, we have to think about where are we going to put the implants. My standard 2-implant position is a paired implant in the lateral incisor or canine location. I want to get those implants as anterior as possible, and it's based on the arch form. Why do we want it as anterior as possible? If you're in the premolar region, we're going to create a rocking motion. Okay, so we need to get anterior so we have vertical retention, okay, and then soft tissue support. Now, occasionally, we're doing immediate implants. We're having a broad, wide, U-shaped ridge, maybe opposing a natural dentition. I may put in a triplicate where I have paired canine location with something with another implant dead center. Okay, so from time to time, do I use triplicates? Yes. The majority of our cases in our office are 2-implant mandibular overdentures. What I was saying and alluding to is for the optimal biomechanical distribution, the general consensus is to position the implants anteriorly and refrain from inserting them in the premolar area. When they're anterior, they lock down, you have soft tissue support, good border molding, good contact of your acrylic, and you have a stable prosthetic platform. When the implants are somewhere near the midline, you bite on the front, it rocks on the back. Bite on the back, rocks on the front, and it creates a seesaw motion. That is what we want to avoid. Okay? And that is why in some situations we are doing immediate implants. We're pressed on time. Patients travel 6-8 hours to see me. I may make the decision, we're going to take teeth out, we're going to put 2 implants in the canine premolar region, and we're going to put 1 in the midline somewhere at the 24, 25, 26 position to now create a tripod stabilizing procedure attachment system. Okay, as the distances increase, the risk of rocking effect of the overdenture increases, so we add a third to stabilize that implant system. And when I typically do that is an arch form that creates a fulcrum, broad, wide ridge, typically with class 2 skeletal relationships, or I may have a maxillary fixed or natural tooth restoration that is going to create a lot of force bearing down on this. So I may look for additional implant stability. And this is a case that this may occur. Okay, we have broad, wide canines, immediate implants that are going to be placed at the time of extraction with the veloplasty. Now, I may have a day where we blow out a buccal plate and I need to shift positions, okay? Or I can't get that implant stable in my primary position. So we move locations, change to a tripod stability platform, and now we can still move ahead with the case instead of letting this patient heal 4 months. Come back, place the implants 4 months later, then come back and restore. We want to have expedited treatment protocols. Okay. So as I said, the paired placement, lateral incisor, canine region based on the arch form. A V-shaped arch form is better than a U-shaped arch form. U-shaped arch forms can kind of create line placement. We want to get it anterior so we don't have a fulcrum and a seesaw motion. If I am more towards the premolar region, I will add that implant in the center of the paracentesis region to create a tripod stability effect. Okay. So after we know our locations, we're going to start looking at the floor of the mouth. This is something I show to the patient with the patient mirror. I place our patient mirror, okay, for the diagnostic handle in their mouth, okay, along that buccal kind of lateral wall there. I have them lift their tongue and I assess how much lateral movement or vertical movement is occurring from their tongue. And I explain to them that their denture is going to move. Now, border molding, we should limit these motions because we're creating a functional border, but they do have to realize that we are going to have posterior motion of this implant, of this denture, because our implants are in the anterior, vertically retaining it. The tongue is not going to rock it around, but the amount of floor mobility is going to affect your fishtail motion. Second big thing I watch for is where is the keratinized tissue and will I have keratinized tissue around those implants? This is a picture of a case that was in my residency that they had placed some implants and they could not expose these implants without the floor of the mouth swelling. You can see there is minimal to no keratinized tissue, and we have to think about that in our surgical techniques. Do we change our approach on the incision design? Do we have to graft ahead of time and increase the keratinized tissue, but we need keratinized tissue around these implants because clinical experience, more than scientific evidence, suggests that we need a thick gingiva, typically 2 millimeters of keratinized tissue with 1 millimeter of attached tissue around our abutments to resist soft tissue inflammation and recession. Think about what our restoration is going to be doing over the next 10 years. We're going to be clipping this in and out, in and out. The patient needs to brush their teeth. So the challenges there become, are we going to have tissue inflammation that is going to constantly be aggravated? And this is where we need keratinized tissue. Okay. Other thing to assess and explain to a patient, if you look on the left, this patient has thicker, ropey saliva, where the one on the right has a dry mouth. Denture retention is a dynamic issue dependent on the flow of interposed fluid with good base adaptation and border seal. If we don't have water between two glass plates, they don't stick together. A denture is the same concept. If we have a dry mouth, they're gonna have soft tissue irritation. They're gonna have less retention because a implant system is implant retained, soft tissue supported. We need both to function together. So this is something I document and talk to the patients about. Next, and the big ones to start paying attention to and remembering as we get to the end of this lecture to the first part is prosthetic precision. Less restorative space requires more strategic management of the attachments. For an implant overdenture patient, the space must accommodate a denture base of sufficient dimensions, appropriately positioned denture teeth, and an implant attachment system. There's a lot going on in this small amount of space. And we have to think about what attachments are available. And you have to remember that all attachments are designed to prevent vertical movement with no conclusive literature stating one system is superior than another. What you have to think about is what has the most clinical applications, what has ease of use. When the patient come back for maintenance, what is easy to change out this retention? Do I have variable retention? So a younger patient that has good dexterity can snap this in and it locks it in. They want to bite into an apple. Versus a older patient, limited dexterity, maybe Parkinson's like disease going on where they have shakes. Will they be able to remove this? How easy is it for me to change the retention? A reported minimum space requirement for implant supported overdentures with a locator type attachment is 8.5 of vertical. So we have to think we're looking at vertical space, but we also have to look at the horizontal space, the buccal to the lingual. We cannot have too bulky of a restoration encroaching on the lingual space, blocking the tongue, impeding speech becomes a critical thought. We have to think in 3D. So when we look at it, okay, and if we take like a locator or a stern snap, we have to look at the vertical space, okay? So there's the working portion, then there's the collar, and then the attachment system. So on average, we need about 5.5 millimeters of space to house that attachment. The width, we need about 5 millimeters. And then we have to think about how much acrylic do we need to surround this denture. And you typically want 3 to 5 millimeters of processed acrylic around these attachments to resist fracture. Implant components, including the abutments and the retentive devices, occupy space. The space should never compromise the contours or the integrity of the denture base, and if the contours are compromised, phonetics, aesthetics, and strength can be negatively affected. So when we go back to this, just because there looks like there's a mile of space, we have to think about where that space is measured from and how much space do we need. So if we said we need 10 millimeters of space, or 12 millimeters of space, where is that space from? The space is measured from your planned incisal edge to your planned implant platform. So we have to have an accurate denture to start building on if we're going to place implants. And if they come in with the denture, we have to evaluate that denture. Is there enough interocclusal space? Do we have a bare minimum of the 8.5? Okay. For me, I want a bare minimum of 12. I want leeway for space. When you think about 8 millimeters of space, that is not a lot of room for teeth, acrylic, and an attachment system. I want a bare minimum of 12. Okay, in our office for a mandibular overdenture, I look for 12 to 15 millimeters of space to have adequate sized teeth, to have 3 to 5 millimeters of processed acrylic. Okay. In all of our mandibular overdentures, which I'll talk about in the restorative section, I add a RPD metal framework into that, okay, in order to prevent fracture. Then we have the attachments, which I told you take about 5 to 6 millimeters of space, okay, in the vertical spot, and then 5 millimeters of space in the lateral. So if their denture has severe wear, okay, the borders are underextended, it's been relined 2 or 3 times, you make this patient a new denture. Do not try to just add implants and then modify it. You're going to be spinning your wheels, okay? And when we think about space, this article does a really good job at explaining space by looking at cross sections. Here's a case that has impressions taken, 2 attachment systems are there, and there's less than 2 millimeters of space for the attachment housing as well as the acrylic. So we know this isn't going to work. What they did is then they removed all of that. They did surgery, placed new implants at the proper depth, showing that they have 3 millimeters of space from the implant to the housing to the denture extension. We need space. Okay, you can't just go laterally or overbulk the restoration. So, other thing, implants must be placed at the same occlusal gingival height for locator type retention. With differing heights, the shorter locator will detach and only the taller locator will receive the load from the supporting tissue. So the denture will start teeter-tottering and popping. They bite, it pops. They bite, it pops. And with that said, the fundamental principles of bone physiology allow for internal loading of the edentulous maxilla and the mandible with an implant-supported prosthesis halting further resorption of the residual alveolus. Proper tooth positioning within the prosthesis also allows for a predictable treatment outcome, addressing proper facial support, normal phonetics, as well as prosthetic design, allowing for proper home care for the patients. With that said, these are a few references, okay? We're going to get into some basic implant surgery at the next lecture. The Color Atlas of the Dental Implant Surgery, the 2nd edition by Michael Block, excellent book. I like the Surgical Complications in Oral Implantology by Louis Farage, fantastic book. It talks about surgical complications, restorative complications, and then it gives solutions, okay? As we get into the 4th part of restorative, this is probably the latest and the greatest on what's out there in terms of digital dentures, new materials and techniques. Journal of Pros on complete and removable dentures. Excellent book. A good update to what's new. With that, I'm going to take some questions. We have parts 2, 3, 4, and 5 coming up as I described. Part 2 will be next week, same time, same place. It will be posted on the boards as was mentioned earlier. So with that, I'm going to leave this slide up and we can take some questions.
Great, great. Thank you, Dr. Hallis. A great presentation and so informative. And there's so many things to, it's different aspects of implant dentures to look at. You know, it's funny. One of the biggest challenges I have is, I think, come across is, but like you talk about the amount of room that's that we have to put attachments, acrylic, and everything in between. You know, so it's that's really important. And I think you know what we try to do also is use a material. It's like an acrylic that's going to have flexural strength and high impact resistance. So it's going to be better on these types of cases with less fracturing. You know, so but we do have some questions in the Q&A box here, so I'm going to bring it up here. The first question is, how do you manage complications related to bisphosphonate drugs? So
that's a loaded question.
Yeah.
So the first is preventative, right? You have to evaluate the risks of this patient. The second, if you really do have a complication where you have basically osteonecrosis occurring, you have to have a team member involved. If you're not comfortable managing that, you don't have hospital privileges, that is where you need to bring in an oral surgeon. So the first I would say on how you manage that is prevention and identification of the risks. If there is one, that's where I would bring in my oral surgeon most likely. I am fortunate, I do have a hospital privileges, but I have a team approach. We have an oral surgeon that I trust. I have a prosthodontist, I have my lab. So really a team approach there would require management.
Great, great. Next question is from Ambreen Khan. She says, how are you measuring interarch space in edentulous patients to plan which implant system and attachment system you will use?
Okay, implant system and attachment system, I'll talk about that in the next coming lectures, okay? Which ones I use, which ones I don't, why I use them, and where we use them, okay? I'll talk about my primary ones. I'll talk about how I use 2 different systems in our office, and we switch through implants. As far as measuring space, it comes from a diagnosis of their accurate denture or a workup. So if a patient comes in with a new denture or an old denture that is not aesthetically functioning right, it is basically, the teeth are in the wrong position. I will take impressions, I will do a wax up, I will do bite rims, and I will do a try-in. At that point, you measure from the planned incisal edge to your planned implant platform. I need 12 millimeters in my goal, okay, and we'll talk about the attachments in the coming lectures, but make sure I have enough space for the attachment system, which typically occupies about 5 to 6 millimeters of space. Then you have the metal framework, the teeth, and the acrylic. So that's why I like 12. There's not a technician probably in DSG lab that will tell you there's not enough space, and the more space you can give them, the better it is. So if I can, I will usually reduce to 15 millimeters because it's a planned incisal edge. Maybe I need different attachments after I'm working on this case and I've realized they're impinging on their tissue. The patient maybe is a little more delicate and it's contacting and it's pinching, and I need to raise that restoration up. So typically I like 12 as my minimum. I prefer 15. I'm sure dentists will agree with that.
Yeah.
So more is always better. So first thing is everything starts with an accurate denture that is ready to be restored. If you're building a new denture, you set the teeth where you need to be, and then you measure from those planned incisal edges.
Right, and then don't skimp on an inner support, an inner framework or mesh framework, because I've seen that doctors try to get away with that, and normally what's going to happen is it's going to break where those attachments are. So it's great to get that 6 millimeters we need around that attachment. That's nice. We'd like even more, but more is better when it comes to that. But
and we'll talk about that metal framework, and I'll show a clear picture of cross section of why you need those metal frameworks. There's not a case that I don't put a metal framework in.
That's great. Yeah. Now we have another one from Robert Lang. Do you have a checklist for patient evaluation?
Yeah. So all my exams begin the same. If it's a dentate patient, it's charting, decide on radiographs, periodontal charting, documentation of findings that I see in the mouth. And a denture exam, I basically go through everything I said. Are the ridges parallel? Is there undercuts? Well, how much keratinized tissue do they have? Are they broad, resorb ridges? What is their throat form? What is the palatal vault design? So do I have a denture exam that I go through that's standard? Yes. Do I have a dentate patient that's standard? Yes. After I do my initial exam, I will always sit down and talk to the patient and find out, hey, what is our plan here? What is our working budget? What do you want me to achieve? I then tailor that to taking the records that I need. Do I take a CT scan? Do I take diagnostic models? Do I need photos? Do I take an intraoral scan? Am I going to digitize this patient? And that starts tailoring what I end up doing. So is there a checklist? Yes. Does every patient start the same? Yes.
Okay, great. And then we have from Robert Salisbury, have you been comfortable with all implant systems from premium to value brands?
That's kind of a broad question.
Yeah.
So I will talk about implant selection in my practice. I use 2 main implant systems in my practice. I use Nobel Biocare. I use the Nobel Active and the parallel walled implants. And then I use Stern Gold's True Implant system. Okay. Have I placed a variety? Yes. Okay. I've placed a ton. I've placed Astras. I've placed Straumann's. We placed the Stern Golds. We placed the Nobels. I will talk about it. A lot of it comes down to technique and then product availability. What is available for me to restore the case? The more products I have, the more abutments, the more angle corrections I can do, the differences that I can bring to that table and solve solutions. So I don't 100% look at cost. I look more at what components are available. What is that implant system bringing to my office? Do I look at then overall the cost and I think about how I can make this more affordable for patients? 100%. And we will talk about that a little bit in lecture 5. We'll talk about that a little bit in lecture 2 and kind of give my perspective.
Great. Thank you. And we got a little note from Len Connor. Great program tonight, Dr. Hallis. We had a lot of people watching tonight, so it's a great program. I'm looking forward to the next four segments here. So you got me on the edge of my seat. This is right up my alley. I know a lot of people have so many questions for the future presentations also. But and we had one other question: is somebody wanted to know if you share your presentation? You know, I couldn't answer that, so I just figured like maybe they wanted the specific slides. I told them to email. I'm going to tell them to email us, and if they maybe want some specific information. So I didn't want to answer it on your behalf, Dr. Ellis. You know, that's about sharing a presentation.
Perfect.
So,
I thought I lost you a little bit there. I heard part of that, but
yeah, they wanted to know if you shared your presentation, your PowerPoint presentation.
some of it will be available on the Sterngold website too. This is all up there too.
Okay, great. And we had something that just came up. Which abutment do you use the most?
And in my office, the most common is the locator followed by the stern snap. We'll talk about why I do that. Just varies on different retention and challenges we go.
Good. All right. Do we have anybody else has any other questions here? We can put them in the chat box, or we can unmute you.
And one of the things on that last question is it's not what the most common that I use. We're going to talk about selecting for ease of use. You know, when I talk about abutments coming up in the restorative section, we're going to focus on where I can use that abutment in the mouth. Will it apply to a mandibular overdenture? Can I use it in the maxilla? How I use it? What is the ease of change in and out? How does it operate in my hands? And then what are the other options available? You know, like the stern snap with the PVS cap. Why do I use that versus the pectin ring insert? And how do I apply that? So I look at broad techniques to simplify the components, because one thing prosthodontists are good at is complicating things. And I have to think about overhead. So we have a lot of parts and pieces. So we'll bring that into kind of perspective.
Great. Thank you, Doctor. Another one just popped on here. How do you measure keratinized gingiva?
So you kind of have to, let's see if I can bring that. I will bring that, I will make a note of that, and I will show that at the next lecture. Okay, instead of trying to flip back through this lecture, I can't really, with the screen sharing, it's not easy. But I will show you that at the surgical incision design part, how I kind of make a decision on what is the width of the keratinized tissue, where do I put my incision, how much keratinized tissue do I want on each end so that the sutures aren't pulling. So I'll jot down a note here and I will show how to measure that. I'll put an extra slide in.
Great. Thank you, Doctor. And I'm not seeing any other questions here in the box. So
we will be here next week. So if there's any other questions, just write them down and we can answer them at that time.
Great. Yeah. Thank you, Doctor. Great presentation. I look forward to next week. And thank you, everybody, for joining us tonight. And I don't know if Jessica had anything else to add, or are we okay?
Thank you very much, Dennis. Thank you, Dr. Hallis. Thank you, Sterngold. Thank you, audience. I do believe Patrick, he wanted to jump in and just say a few words really quick.
Certainly, yeah. Thank you, this Patrick Hayden with Sterngold, and thank you, Dr. Hallis, once again for just a really great program. And thank you, Jessica and Dennis for your support and your co-sponsorship with this. And we all, hope that all of you out there, the attendees, really found value with this, with Dr. Hallis. And we hope this improves your cases moving forward. And we hope to see you at the upcoming 4 courses over the next 4 weeks as well. So thank you very much.
Thank you, Patrick. And again, audience, the contact information for both Patrick, Jean, and Dennis are in the chat box. So feel free to reach out to them during the week before session number 2 if you have any further questions or concerns. And with that, I will turn it over to Dennis to take us out in his positively positive way.
Okay, great. Thank you, Jessica. And it's the ultimate goal here is patient acceptance and functionality and patient acceptance. And with information that Dr. Hallis has given us tonight, I believe we can utilize this and achieve that. So thank you, everybody, for joining us tonight, and thank you to Dr. Hallis and everybody at Sterngold also. And thanks, Jessica. Have a great night, and we'll see you next week. Take care now.
Bye for now.
Okay.